All right. Well, thank you, Alyssa, for inviting me, and thank you everyone for being here. Um, my talk tonight is going to focus on the history, current status, and ethics of plastic surgery mission trips, and as well as some of my own experiences with these trips. So shout out to UB. This is me graduating in 2014. I'm still friends with all these people. So I had a great time being in Alyssa's position about 10 years ago. So this is cleft mission work. This is my first mission trip almost 5 years ago in Mexico. I was a resident at the time, and this really helped foster both my interest in cleft and craniofacial surgery, as well as global mission work that I continue to do today. So just a brief overview of this talk. I'm going to discuss the history of medical and plastic surgery mission organizations, the current status and some of the major organizations, some of the approaches and models, some ethical issues associated with this, and then end with some of my experiences. So what's a medical mission? You guys are probably more familiar with this than most people in medical school. So basically, it's just a group of people administering medical care, generally to people that they wouldn't typically be taking care of. So either geographically or a different socioeconomic group. It often, kind of traditionally refers to Christian organizations. The word mission sort of has that connotation. And a lot of that comes from the fact that some of, healing the sick and evangelisms are tenets in the New Testament. And this is not a religious talk in any way. I'm not a religious person, but I'm just, it's something that is where this sort of comes from. Usually it refers to Western groups traveling to countries that are generally impoverished, or at least have, are underserved in whatever sort of medical care is being offered. We often now kind of get rid of the word mission because of the religious undertones that it may have. And most of these groups now are often are not religious. And so we may call it medical service trips, global outreach, global surgery or health, humanitarian aid, et cetera. Lots of different terminology for this type of work. So the history has some sort of not so great undertones to it. So colonialism and religious missionaries from Europe were prominent throughout the 1700s to the early 1900s, really focusing on obtaining land and spreading religion, mainly Christianity, to Asia, Africa, and North and South America. And medical care was incorporated in this, sometimes with good intentions, but sometimes as a way to convert people to their religions. And so, there were some good things that came out of this, but some also not so good things. However, it was this guy, E.C. Bridgman from Massachusetts, who was serving as a Protestant missionary to China, not a medical missionary, who noticed that the outcomes of cataract treatment by the Western missionaries were better than those of the local Chinese doctors. And, this was just kind of an observation he had. So he said, well, maybe we should bring some more people here to do some work. So this guy, Peter Parker, was the first Protestant medical missionary to China at this gentleman's request. Some other Americans followed and formed the Medical Missionary Society of China, which is the first society for medical missions in the world, according to my research, at least. There may be some groups that were, did not go documented and didn't get this recognition. The Edinburgh Medical Missionary Society was the first European organization and ran until fairly recently. So when did plastic surgery come into this? Plastic surgery is a pretty new specialty, in that it has a name and is, recognized as a specialty, but plastic surgery has been performed for thousands of years in some way or another. But the specialty really took off in World War I. In World War I, there were a lot of really traumatic injuries and people actually survived. So they were extremely disfigured, but alive. And there were surgeons that took it upon themselves to figure out ways to reconstruct these people. But most of World War I and World War II took place on Western land. So there wasn't necessarily medical missionaries, because it was, in Europe where most of the missionaries come from. That is until the atomic bombings in Japan. And so in this, there were 25 girls and young women who were, noted to be severely disfigured by the bombing in Hiroshima. And these people were initially cared for by Japanese surgeons, but they weren't having a lot of success. They had really horrible burn scarring and contractures and disfigurements. And a journalist brought attention to these women, and it kind of got into the media, and Americans, probably feeling pretty guilty about what had happened to these people, donated money to help them. And rather than US surgeons traveling to Japan to take care of them in kind of the traditional mission style work that we know about now, these women were brought to the US and they were taken care of at Mount Sinai Hospital in New York by these plastic surgeons, and reportedly had pretty good success. There were other wartime missions that came out of the world wars. So kind of these same Mount Sinai surgeons that took care of the Hiroshima maidens took care of these Polish survivors of Nazi medical experiments. They had bacteria injected into their soft tissues and had horrible necrotizing infections that led to really bad soft tissue destruction and deformities. And these people were also brought to the US for treatment. In the Vietnam War, we started to see more of the kind of traditional model of people going to other countries to care for people. So the Children's Medical Relief International was a temporary hospital that was set up in Saigon, and there were volunteers, plastic surgeons, pediatricians, and anesthesiologists from around the world that volunteered to work there. Some of the same people from the Hiroshima maidens and from the concentration camp victims. And these people went to Vietnam to take care of these kids. And there was collaboration with the Vietnamese people. And so this was, kind of an example of more like what we do today. Also formed out of war was Doctors Without Borders. So this organization was founded in France in 1971 after the Biafra secession. And this organization did not have a political or religious affiliation. This is not a plastic surgery organization either. This is, kind of a, general medical care sort of group. And they have also set up refugee camps for people who were affected by the Vietnam War. So a lot of what we do today in terms of global health came out of war. So when did classic cleft and craniofacial missions that we know about come from? It's kind of unclear where this really started, but since people were already doing mission work in Vietnam, it seems that it likely started out of that. So humanitarian aid missions to Southeast Asia that noted that there were children who had these congenital anomalies. Some of it may have been increased related to Agent Orange exposure from the war, but also those of us who are interested in cleft and plastic surgery know that Asian populations are twice as likely to have cleft lip and palate. So there may have just been a lot of kids with cleft lip and palate that existed there and, suddenly were noticed. So not too long after this, Dr. William McGee founded Operation Smile. He is a plastic surgeon who trained with Dr. Paul Tessier, who is one of the, founding fathers of craniofacial surgery, and formed this group to travel around the world and help kids get cleft care. And this was inspired by a trip that he took to the Philippines. And it's important to note that this guy is an actual, cleft and craniofacial surgeon by training. We will talk about a little bit of the ethics and, of people who aren't trained in this that try to, go out and do this work. And this is out of date statistics here. I think this is from like 4 or 5 years ago, but Operation Smile to date has probably performed 500,000 free surgeries at this point for, kids all over the world. And also, one of the things that they're trying to work on is having established care centers that provide year-round care instead of just, showing up, operating and leaving and not having any sort of, place to get care after that. So a couple of people who previously worked with Smile Train or with Operation Smile started Smile Train in 1998. And this group is similar. They also travel around the world to provide cleft care, but their focus was, the difference between them and Operation Smile was that their focus was to train and support local surgeons to be able to do these things rather than just fly in doctors from, Western countries to perform cleft operations to, create more sustainability in their mission work. And their first missions were to China in 1999. In 2014, the organization performed its millionth cleft operation. And Smile Train has, done a lot in the media. So, Operation Smile and Smile Train are kind of things that, regular people who are not involved in plastic surgery or cleft care or even medicine at all know about, because there's commercials and ads and things for these groups. They got Aishwarya Rai to be a global ambassador, who's a well-renowned actress, and Smile Pinky won the 2008 Oscar for Best Documentary. And this is about a little girl in India who had a cleft repair via mission work. And this was sponsored by Smile Train, and they have surpassed Operation Smile as the largest cleft charity group in the world to date. And it seems that there's some, kind of tiffs between these two groups. It seems that they don't necessarily get along super well. So there's some bad blood there. But I think ultimately these people all have good intentions and have the same, goals in mind to help kids. There are dozens and dozens of these cleft groups around the country on a much smaller scale than those two groups. And so I will briefly mention two of them that I am involved with. So this is Advent Health Sharing Smiles. This is a group, Advent Health is a big healthcare organization, not in Western New York, but in the Southeast. They have a lot of hospitals. And so some of you on this call may know about them. They have this group Sharing Smiles that goes to Central and South America to do cleft work, also dentistry and physical therapy. And this was that first trip that I went on with this group, and I'm hoping to go back to Mexico with them this spring. And so this was really my intro to them. And this is Hugs. This is a local organization to me. This is a group out of Rochester, New York, founded by a facial plastic surgeon, Vito Quatella, in 2003. And they focus on cleft lip and palate, as well as microtia, ear reconstruction for kids who are born without ears or with malformed ears and other facial deformities, and do trips to Guatemala, Ecuador, Peru, and Vietnam. And these pictures were taken just, I guess, about 2 months ago on our trip to Guatemala. A little girl with a cleft lip that we repaired. I tried to steal her, not really, but she was very cute. And then this was some of our team that came from Rochester. And it's important to note that all of, these people on the right, that's me and my Buffalo Bills cap, go Bills, are playing tonight. Dr. Morrison, he is my partner at work, our other pediatric plastic surgeon. And then this is Lisa, she's a CRNA, and Taylor, who's a PACU nurse. And all of us are doing things that we do in our normal jobs. So we're not people that are, faking being plastic surgeons or CRNAs or PACU nurses, that's stuff that we do normally. So, assuring that these kids are getting appropriate care. So there are lots of other types of missions. Plastic surgery is my specialty, but there's mission work for anything you can think of pretty much. Other things that you can do within plastic surgery are burn and hand surgery, and there is mission work for those things as well. So mission models. This is pretty much adopted from a paper that was in one of the plastic surgery journals, where they talk about different types of models that one can take for global surgery. And they discuss a vertical one-way, a vertical two-way, a horizontal, and a diagonal. And I don't know that this terminology is used anywhere else, but it makes sense to me, and is kind of a good way to think about these things. So a vertical one-way mission group or trip is like your classic cleft trip, where you have a team in the United States or wherever, and you pack up all your stuff, you bring your supplies, you have a specific amount of time you're going to be there for, maybe a week or two. You do a bunch of surgery, you fix a specific problem. It is usually privately funded by donors, people are volunteers, you do your thing, and then you leave. And there are advantages and disadvantages to this. So advantages, it is pretty fast. It is attractive to donors. They donate money for a surgery. They see the kid before and after, and they feel good. They helped, accomplish this goal. It's pretty efficient, and it's been going on for years. So it's a pretty traditional and, effective way to do things, but there are lots of disadvantages. So it doesn't address the cause of the problem. It doesn't address the sustainability or the ability of this, this place you're going to be able to, sustain this. It may increase dependency for that reason. And there may be kind of redundant efforts. So there's lots of these groups. Maybe they're all going in the same month, and then there's not going to be enough kids to even operate on. And then nobody's going to go for the next year. You just don't know. It's unpredictable. So a vertical two-way, kind of the same thing. But this can also include bringing patients to you. It's kind of like the Hiroshima Maidens. It could also involve trying to train a surgeon in your country, but basically, similarly, not sustainable. Horizontal is kind of ideal in some ways. This focuses on the long-term infrastructure. It's a big investment, and advantages are it would strengthen the system. It would benefit patients for years to come. It would create a long-term change. The disadvantages are, probably even outweigh that. So these things take a long time. There may be limitations based on the local government or just society as a whole, preventing, whatever is lacking from happening. And it's difficult to, measure the impact of these interventions. You don't just, somebody donates money, they don't get a cute picture of a kid whose cleft lip was fixed. They get a picture of like a cinder block that's maybe going to build a hospital someday. And it's just kind of less satisfying for those people. And so diagonal is kind of the best of both worlds. So combining your immediate gratification that you get with a vertical model with the long-term benefits of a horizontal model. So, you can keep doing trips, but in some way impacting the infrastructure and making long-term changes. And I would like to think to some degree that our partnership with Hugs in Guatemala is doing this. And I'll explain why I feel like that once I get a little bit further to my own experiences in this, in these trips. All right, so the ethical issues. This is much less fun to talk about because, all this sounds really nice. We go and we help people, but, are we really helping? And as I got invested in this kind of work, I had a lot of questions. And so I don't know that I can even answer all of them, but I'm going to do my best. So here's the questions I had. Is this good surgery? Are we doing good operations, and what are the outcomes? And how do we even know what the outcomes are? Are these people that are going on these trips qualified? I know I'm qualified, but I didn't know about the people around me. Are the facilities safe? We're obviously not operating at, a tertiary care center in the United States, but, what is this like? Do we have all the things that we need? Is it clean? What about follow-up? What happens to these kids after you leave? And what happens with the rest of cleft care? So any of you who have ever experienced, a cleft and craniofacial center know that there's a lot of people involved in these care. the care of these kids. You don't just have the surgeon, you have a speech pathologist, and you have otolaryngology, and you have a dentist and an orthodontist, and maybe even a psychologist. And so if you don't have this whole team, are these kids benefiting? This is a big one. Are these countries not creating their own infrastructure because someone else is just going to come and take care of everything without them doing that? What racial and cultural issues might be involved? And then at the same time, is potentially subpar surgery better than nothing? Is having a not great cleft lip repair better than, being 20 years old and having a cleft lip still? With the social implications of that, maybe it is better than nothing. And so maybe none of this is that important. So here's a scenario. So here's, this is a stock photo, so I really hope this isn't a real doctor, because that would be embarrassing. But here's some hot doctor, plastic surgeon in Hollywood who does, cosmetic surgery and works in this fancy office and takes care of people like this and, makes $100,000 per facelift. So, this guy's a good surgeon and he's ultimately a good person. There's nothing wrong with doing that for your career if that's what you like to do. But, once a year, he likes to go on a trip and take care of kids with clefts because it provides him with, some job satisfaction, makes him feel good, and, gives them a little bit of positive publicity. So people like him. And everyone's like, that's great. Good for you. Thank you so much for doing this important work. So the same dude, this Hollywood doctor is in his office, and in walks this baby, and he has a cleft lip, and his parents saw, oh, plastic surgeon, we're just going to go in there. But this is an American baby. And it would be pretty weird for this guy to fix this kid's cleft lip. I mean, there's probably an actual, person who did a fellowship in this and does this all the time. That would make way more sense to take care of this baby. So suddenly, the same guy that we were cheering for before, we're like, that's, that doesn't seem quite right. And so, why is this baby any different than this baby? And, why wouldn't they get the same care? So, and are they getting the same care? So there's some, research on this. It's a little bit hard to do studies on mission work because we don't always have, good contact information for the patients and good follow-up, but this group did a pretty good job trying. So this group compared fistula rates among patients after cleft palate repair in 3 groups. And so for those of you unfamiliar, this is a cleft palate before and after repair. You can see it has a scar down the middle of it, but it is intact. And one of the feared complications of palate repair is a fistula. So, it gets a hole in it. So that's what we're monitoring here. So 3 groups. So kids in the US repaired in the US at in San Francisco at their established craniofacial center. Chinese children who were repaired at their established institute in China by presumably qualified people, and then Chinese children repaired by international teams through Research International, which is a mission group. The research team consisted of 15 board certified or board eligible plastic surgeons. So these are real plastic surgeons who did a real residency and are presumably qualified to do this. So they actually found a lot of patients, and the follow-up rate was about 60% for the international group. So we had, quite a few patients to look at, and the fistula rates were calculated, and those who were repaired at UCSF had a 2.5% fistula rate, which is good. That's probably what would be expected around the country, I would think. The Chinese kids who were repaired in China at their institution had a 12.8% fistula rate, which isn't great, but not completely ridiculous. And then the research humanitarian team had a more than 1/3 fistula rate, which is crazy high. And these are plastic surgeons. Now, I don't know that they specify that these are plastic surgeons who do clefts usually, but all plastic surgeons have learned how to fix clefts in order to graduate. In older age and cleft severity were associated with fistula formation. So why were these rates so much higher than at home? So they took a look at this. More technically complex palates were repaired in older patients. So we repair palates around a year old in the US. And sometimes on these mission trips, you repair palates in much older kids. The environment and the equipment are different. They also quoted another study where Peruvian surgeons' outcomes were tracked during missions and in usual practice, and they had a much higher rate on missions, even though they're the same, literally the same people doing both of these operations. And so you may blame it both on patient factors, equipment factors, surgeon experience. So this group requires board certification or eligibility, and letters from other plastic surgeons vouching for their experience with cleft repairs. Doesn't necessarily mean that they do this stuff on a regular basis, but they're capable of it. And they didn't have trainees going rogue fixing these things. So their fellows were supervised. They weren't just, they didn't just have like residents and fellows, practicing. And then lack of or deficient post-op care. So nutritional deficiency is probably a factor. We all know that wounds heal better in people who have good nutrition. Adherence to instructions, that could be language barrier issues. After you fix a cleft palate, the patient should be on a soft diet for a few weeks, which is not that much of an issue in a baby because they often don't even have teeth and their parents have complete control of everything they eat. But if you're fixing a cleft palate on a 7-year-old, they could be, sneaking Doritos. You have no idea what they're eating necessarily. So that could certainly play into it as well. This was another study that was kind of interesting and eye-opening as someone who has done mission trips in Mexico. So this was characterizing Mexican cleft surgeons' own practices and experiences with visiting surgeons. And this was an email study. They had 81 respondents. So this quote was interesting. So decades ago, the Mexican craniofacial surgeon, Dr. Fernando Ortiz Monasterio, coined the term surgical safari to describe visiting surgeons who came to Mexico to perform cleft surgery on Mexican children, but who left behind serious complications. These complications occurred because visiting surgeons operated outside of their scope of practice without proper follow-up care. And he's right. About 2/3 of the respondents had direct experience with patients operated on by visiting surgeons. And of those who did, more than half of them had performed some kind of corrective surgery on these patients because of complications from the surgeries by the visiting surgeons. And really eye-opening, almost 3/4 of these surgeons were never paid for the corrective surgeries that they performed. So somebody came, they did surgery, it didn't go great, and somebody else had to deal with it, and they didn't even get paid for it. The surgeons also were asked to grade the visiting surgeon's outcomes based on functional and aesthetic. So functional outcomes, about 3/4 of them were anywhere from acceptable to excellent. Very few were excellent, and a quarter of them were poor. Aesthetic outcomes were pretty abysmal. Only 5% were excellent, 14% were good, and the rest of them were acceptable to poor. And I'm sure there's some major bias here. I mean, it sounds like a lot of these people who are answering the survey in the first place probably had strong feelings, which is why they bothered to answer it. And then, they're going to be a little bit biased here, but that's really pretty terrible. And then the Mexican surgeon's assessment of visiting surgeons' role in Mexican cleft care, 2/3 of them were basically like, we don't need anybody else. A third said that it would be helpful in collaboration. And then 4% said that it was useful for help with surgical backlog. So not too many people seem to really want visiting surgeons there. So our volunteer surgeons qualified. I've brought this up a few times because we have people in the US who are doing surgery that they're not qualified to do. This isn't a unique problem on mission trips, but Operation Smile takes this very seriously. I was looking up their qualifications, and you have to be registered in a relevant specialty that includes cleft lip and palate surgery. So basically plastic surgery, ENT, or oral maxillofacial surgery are specialties in which this is in the scope of practice. You have to demonstrate current cleft experience and current professional training. So current cleft experience, I don't know if that means you do this stuff, every day, or if you do a lot of mission work, but that's super important. And you can't just retire and go on mission trips for the rest of your life. That sounds kind of fun, to be honest, but they don't want people who are out of practice. And, if you're not operating because you're retired, maybe you're a little old and they don't necessarily want you operating. So, they take this pretty seriously. So language barrier. We experience this at home too, where you're talking to patients. You may even have an interpreter and you're not sure if they're totally understanding everything because the instructions are not in the appropriate language. So this is a big deal. Qualified interpreter should be present. And it was pretty eye-opening to me when I went actually on with both groups to Mexico and Guatemala. I figured we're going to Mexico and Guatemala. They speak Spanish. That's easy enough. I'm working on getting more fluent in Spanish. I do speak Spanish, but I would like to speak Spanish better if I'm going to continue to do this work, because it's really, it's only fair for the patients. But we have a lot of Spanish speaking people on the trip with us, lots of, qualified interpreters, until you get patients who don't speak Spanish. So on both of these trips, we regularly have patients that speak Mayan dialects. And so we have multiple interpreters. We have an English to Spanish interpreter. We have a Spanish to Mayan interpreter. And then we're getting a game of telephone eventually. So I'm sure there are things slipping through the cracks. So even if you think you know the language of the country you're going to, you might not. And so there has been work on creating guidelines on plastic surgery mission trips. So I'm not going to, go through this in detail, but there are published guidelines, and they're common sense things, making sure that you have the ability to sterilize things, making sure that you have appropriate medications, et cetera. You should have the ability to, intubate somebody if they're not doing well after surgery. You should have a crash cart. You should have, the ability to resuscitate people. All of that is important stuff. And global health work is, it's a thing that we do because it's helpful to people, it's helpful to us, but it's also an important part of medical training. And so, for me, it was a really great experience to get to do this as a resident. And, all of the residents, basically 94.7% of the residents that were surveyed in this study said that their experience on a global health trip was a valuable part of the residency training. And I completely agree with that. It's just an eye-opening experience. You see things that you wouldn't see at home. You get an appreciation of everything that we have at home. And so having this opportunity is a really great thing. So I highly recommend anybody participate in it that can. So we have a little time left. So I'm going to talk a bit about my experience on cleft trips. This was taken just a couple months ago on my most recent trip. So this was my first trip. This was to Mérida, Mexico. It's the capital of the Yucatan. It's a nice city. This is the operating room, the middle picture. And, it doesn't have any windows. It's not fancy, but it doesn't look that different than an operating room at home. I mean, this is a hospital. They have, normal hospital things. It's very low tech. They actually they didn't have any computers there. They wrote orders on paper, relatively low tech, but we're not operating in a tent somewhere. I think people have kind of this impression that we are, like doing field medicine, and there are mission groups that do field medicine, maybe not necessarily for plastic surgery, but for other specialties. But this, I guess on the grand scheme of, mission work, this is fairly bougie. We have, a lot of, good equipment here, and we bring a lot of it ourselves, but the facilities are there. And this is me with one of our patients. And so what when I'm kind of vetting these groups of like, do I think that this is a good trip to go on? What really made me feel good about this group was this woman. So this is Dr. Maria Flores, and she's a plastic surgeon who works in Merida, and she does cleft surgery in Merida. And she, I'm hoping, is one of the people that did that survey of the Mexican cleft surgeons and said that we were helpful as, visiting surgeons to help with backlog, or at least collaboration. So she just gets overwhelmed. She also does, I think, general plastic surgery, but she gets really overwhelmed with the number of cleft patients. They come from all over the Yucatan Peninsula. They come from Belize, and she can't keep up with it. So a few times a year, she has a mission group go and just help her with backlog. She also, I believe, had a cervical fusion, and she has trouble doing so many cleft palate surgeries because they're very hard on your neck. And so I know when I leave that she's there. And if these patients have a problem, that there's, a qualified surgeon there, and they also have a speech pathologist, and they have access to dental care. Some of these kids that come from really far away don't actually receive that care because it's not feasible, but it's an option. And so that's what makes me feel like this trip is, is worthwhile and is safe. So the other group I'm involved with is called Hugs, out of Rochester. And this is the group that I went to Guatemala with most recently. And this group has created this really incredible partnership with a group in Guatemala called Tess Unlimited. And this is Tess. She is a person, and she's holding a very cute baby. And Tess is really just an incredible person. So she helps provide cleft care for kids throughout Guatemala. And her story is fascinating. So sometimes she's Dutch, and I think she was in college or maybe shortly thereafter. She went to Guatemala for fun. She wanted to learn Spanish, and she wanted to learn how to salsa dance. So fast forward, I think like 15 years, she's still in Guatemala. She married the salsa teacher. She learned Spanish, and she fell in love with these kids. And so she started out by noticing that some of these kids were really malnourished. So kids with cleft palates can't breastfeed. They can't create suction. And so that's how babies are fed in Guatemala for the most part, especially remotely. These people don't have access to formula and bottles and things. So if they can't breastfeed, they die. And she found a way to get, a lot of stuff donated, and, goes around Guatemala and helps these people learn how to feed their babies. And so in doing that, she identified a whole bunch of kids with clefts that needed surgery. And she screens these patients for surgical missions, and she provides follow-up care. She's not a doctor. She's not even a nurse. She's not a medical professional, but she's kind of taken on this role of finding appropriate medical professionals for these kids. And she keeps expanding. So she wants these kids to get the care that any cleft kid should get with dental and speech and orthodontics, et cetera. So she is really working on expanding access for these kids. She also works with Smile Train, and they are working on educating a local surgeon in Guatemala who can, help take care of some of these kids. And, there's no way he's going to be able to do all of the surgeries for all of them, but it's a start for sure. So this is Tess's Instagram, Tess Unlimited Guatemala. If you're interested, you should follow her because she is just an incredible person, and she posts a lot of interesting content of, all the things that she does. And she also sends us post-op pictures. So Clint Morrison, he's my partner at work, and he is a cleft surgeon, and he's been going on trips to Guatemala longer than I have. And so Tess sends us post-op pictures. So it's really fun. We get to see how the kids are doing. She's also extremely picky and judgmental of her surgeons. So she will not let her, her kids, they're not her kids, but let these kids be operated on, by unqualified people. So this was literally just this week, she posted this on her story, but that this kid had a horrible cleft lip repair. It doesn't look good, and he doesn't deserve that. And we see this a lot, as opposed to this beautiful bilateral cleft lip repair that was done by one of the surgeons that she partners with. I'd love to say I did it, but I did not. So why are we even there? Why don't they just get their own surgeons? Good question. And it all comes down to money and resources. So Guatemala doesn't have a plastic surgery training program. You can't become a plastic surgeon in Guatemala. It's not possible. So surgeons who leave, they do have general surgery there. Surgeons who are, Guatemalan who leave to train in plastic surgery sometimes don't come back. Or if they do come back, they've racked up debt like we have, and they want to do cosmetic surgery and get paid. These families can't afford to pay for the surgery, and insurance isn't good there. So they rely on volunteers to do surgery for free. And, if you are a person who has your job as a surgeon in Guatemala, you do need to get paid somehow. And I'm very lucky. I make a salary here. So it doesn't matter if nobody pays for their surgery, I still get paid. So they don't have that luxury. Mission groups can do a lot of surgery in a short period of time. So it can consolidate transportation. Tess can, rent a bus and get someone to go pick up a whole bunch of kids who live 12 hours away, drive them to Antigua, which is where we do our surgery in Guatemala. We can take care of all of them, keep them there for a few days and check on them, and then send them all back. So it's efficient. And, Tess and Hugs, they rely on donations and volunteers. And so it's a really complicated situation. So what do I get out of global health work? A lot. So a personal sense of pride. It feels good to help people. It feels good to volunteer and do something good. Admiration for these incredible parents and how much they trust us. Every time I do this, I just think of how insane it is that we show up, we meet the patients for a very short period of time, meet their families very briefly, usually don't speak the same language. And then they haven't looked us up on Google reviews or Doximity. They don't know if we're good. They don't really know who we are. And they just hand us their baby. And it's so crazy. And it makes you feel like, wow, that's insane, but also, gives you pride because they trust you. It allows me to improve my own skills. So I don't, I fix cleft lips and palates at home all the time, but I don't do, 25 in a week. So it's nice to kind of, really feel like you kind of hone your skills once in a while. It provides me teaching opportunities. So I bring residents on these trips, and it's fun because I get to do 25 in a week, they get to, observe and help with a lot of the same cases over and over again. So by the end of that week, they feel really good about, their abilities to do these things. Cultural and language immersion. It's fun to go other places. And, I really want to be good at Spanish. And so it's nice to kind of immerse yourself for a week at a time. By the end of the week, I feel, pretty good about it and start thinking in Spanish. And then I come home and I forget everything. So it's nice to be there, and the opportunity to travel. I love traveling as just part of my everyday life, and so getting to do two things I love at the same time is just really awesome, and not a thing that everybody gets to do in their job. And appreciation for the resources we have. So it is, it's really easy to kind of overlook everything that's in the core of your OR. There's so many things in there and you have so much stuff. And it makes you, really appreciate that because they don't have all that. And it also gives you perspective on how wasteful we are. The amount of garbage at the end of surgery that we throw out is wild. And so, you definitely don't have quite that level when you are on these trips. It's also changed a little bit about how I do things. So Dr. Morrison used to use, I think, 3 different stitches to do a cleft palate. So, one size for this, one needle for this. And when he started doing these trips, he realized that was kind of annoying to bring all those different things. So he just started using the same stitch for the whole palate. And now he does that at home. And now I've adopted that at home too. So, it teaches you things and makes you realize that maybe we're doing things because we can and not because we need to. And so there's some takeaway points. I think ultimately when we're looking at global health, we should be kind of working towards that diagonal model. You don't want to just go places and do things and leave and kind of, leave a trail of dust behind you. It's nice to be able to help, improve infrastructure every time you go. Ensure that the people that you and the people you're volunteering with are qualified. Take pride in your work. This isn't a time to practice. This isn't a time to, get sloppy. These patients deserve your best. Be culturally sensitive. Don't make it a surgical safari. Make sure that you adopt the customs at home, or the customs where you are. You don't just act like you're at home, because maybe they have different rules. And the ORs that I've been in, they have different rules. And so you have to follow them. Understand that not everyone wants you there, and be safe. This isn't like taking pride in your work. This isn't a time to, get sloppy and cut corners, and just really enjoy and embrace the experience. And so, thank you guys so much for listening, and I would be happy to answer any questions you have.
Thank you so much. That was such a good talk. Does anybody have any questions? Feel free to put them in the chat as well. If not, I have a question. Oh,
sure.
Is there any?
I was going to say, if you think of a question later, or anyone who's listening to this recording has a question, Alyssa has my email, and you guys are welcome to reach out to me anytime.
I have a question.
Definitely.
Sorry, I have a question if no one else wants to go.
Sure.
So firstly, thank you so much for talking to us. This was super informative. So as a med student, I feel like a lot of these opportunities are kind of inaccessible to us, or maybe more so for residents, or like you'd have to take off some time to travel to different places. I was just wondering if you were aware of any way, or like any programs that allow med students to kind of like hop on board, even if it doesn't require like necessarily traveling out of country, or just like in a limited capacity that like we could help.
Yeah, so I don't have any specific examples. I know that for the most part, when at least the groups that I've gone with, they want everybody to have a job to do. So having people just hanging around isn't usually super accessible, but there are definitely things that med students can be helpful with on these trips, like organizational kind of things. We have people that are there just, sometimes just taking pictures, which, we use to raise money and stuff like that. And so the groups I go with, I don't know of a lot of med student opportunities, but they definitely exist. And so, reaching out to groups and seeing if there's anything that you can do, kind of from an administrative side. One of the jobs that our Hugs group is always looking for is here at home is like people to help pack, people to help organize. And so, having a regular volunteer who's a non-medical person sometimes isn't ideal. It's nice to have somebody who has some medical background, who knows a little bit about what's going to be happening while you're there medically, to know, what's important to bring. So reach out to your local organizations and just see if there's anything. It can't hurt.
Okay, awesome. Thank you so much.
That's really great advice. Sounds fun. My question was more towards, in terms of getting time off during residency, were you able to go as part of your curriculum for residency, or is that something that you had to take time off, or kind of like what Avia was saying?
So I had to use vacation to go in residency, which was fine. It's not relaxing, but it was, it was worth it to me. The ACGME, or at least in, I don't know about any other, types of residency programs, but in plastic surgery, there used to be really no extra time off. It was kind of vacation or nothing. But I think probably 3 or 4 years ago, they became a little bit more flexible with leave. And so there is a little bit more opportunities for time. And my program decided that they were going to make the week off to go kind of an elective. So the residents actually don't have to take vacation anymore. Unfortunately, the cases they do on the trips don't count towards, we have to have a certain number of, case numbers to graduate from residency. So the cases they do they don't count, but they don't need those numbers. They get those numbers at home. But yeah, they don't have to take vacation anymore, which is nice. So when you guys are out, interviewing for residency programs, if this is something you're interested in, don't ask about time off because that doesn't really look good on an interview, but ask about international opportunities and, what they have available, because, it's really cool to be able to do that stuff.
Kind of a follow-up to that too, in terms of career-wise as an attending, are you able to go as part of your vacation, or is it as part of your work? Because I know you're talking because you are salaried.
Yeah, so when I signed my contract, I made sure that this is not part of vacation. So I really wanted this to be part of my career, and I teach residents when I'm there. I'm an academic, so life's a little bit different when you're in academics versus like if I were in private practice or something, then yeah, you just kind of don't make money that week. But yeah, so it is not part of vacation for me. I usually work harder on mission trips than I do at home. So it's not relaxing. So I made sure that was, kind of negotiated. So, pro tip for your future career.
Yeah, that's definitely a pro tip.
I have a question about just sustainability and capacity building. Thank you so much for giving this talk, by the way. This was actually really informative. One of the things that I found most intriguing was in your last couple of slides, you talked about the importance of improving infrastructure every time you go. Which I think is a really good tagline for sustainability. And I'm wondering, is that actualized in the groups that you currently volunteer with? And if it's not, how can that be actualized? So for example, the groups that you travel with, do they do trainings in countries that, don't have the necessary surgical training programs, for example?
So it's a great question. And I think everyone would love to know, a great answer to that. I think that it is really important to, when you go to these places, to form relationships with people who are going to, to be there all the time, the people that live there. And so our relationship with Tess has hugely improved, what we're able to offer. And we do try to, do something every time we go. So I think in June, I wasn't on this trip. Our group, Hugs in Guatemala, brought aboard a local surgeon. He lives in Guatemala City, which is about an hour away from Antigua. And he recently finished residency, and he did his plastic surgery training in Mexico because he couldn't do it in Guatemala. And he came back to Guatemala City. So they had him come and do some training with them. And then he was able to do things that were really helpful once they left. So he took some drains out, and they did some, complex ear reconstructions on that trip. So he took some drains out, took some sutures out, was able to manage little complications. And then when we went back in September, he was with us again. We did a little bit of cleft training. So, so it was cool. It felt like we were kind of, leaving something behind, better than it was when we got there. And so even though it was just a small thing with just one person, I think that it was very helpful. And, providing education and things like that is one of the ways that you can improve infrastructure. But it goes both ways. You need to have people in the place that you're going to help maintain things.
Thank you.
Mm-hmm. Anyone else? Well, thanks so much for being here, and you guys are always welcome to reach out to me if you have any questions about anything. But good luck with your future endeavors, those of you in residency interviews. Yeah, you guys are obviously all doing great things. You're part of this group, so I'm sure you're all doing amazing.
Thank you so much. We really appreciate it. I'm going to stop the recording now.
All right.